welcome everybody. Welcome to our this very special webinar. Actually, we call the industrial webinar. This is the first time we're trying to launch such a webinar to introduce the latest technology advances in our radiation oncology communities. So I think some of the companies they have the occupied the advanced technology. So that's why we try to run this webinar to bring our some of the latest news and advances in the medical physics. So today we have our moderator is Professor Chu from let me introduce Professor Chu. He was a professor and the senior physicist in the Department of Radiation Oncology of ACPSEM Medical Center, University of Austin College of Medicine, Seoul, Korea. Professor Cho had over 15 projects and published over 60 SCI papers and over 40 KSCI papers. Also, he did over 60 times international presentations and with more than 6 patents. So, Professor Cho, I will pass on the microphone to you to handle this webinar.
Okay, thank you, Professor Jin, for the introduction. As Professor Jin already mentioned, this is the first time we prepare the industrial webinar. Hopefully, we can give opportunity to the vendors introduce their new products, and also for our audience to share the experience from the expertise in their products. So and also so clearly this industrial webinar is sponsored by Red Formation. So we will get a brief time for the introduction of the Red Formation by Benjamin Moore. He's the director of the Asian Pacific regional sales part. So please welcome Benjamin Moore.
Thank you so much, Professor Cho. Yeah, and thank you everyone for your attendance. We're very excited to be partnering on this webinar, and I think it's a really great initiative. What everyone's doing here. So, can everyone see my screen? Everyone see my slides? Have they come up?
Yes.
Yep,
yeah. Perfect. Excellent. So yeah, look, again, thank you so much once again. We thought it's a really good opportunity for Radformation to introduce ourselves, our company, and then we'll hand over to Jeffrey for the educational side of it. So we are quite an emerging company. We've only been in the APAC region for about 2.5 years. So, but we just wanted to give you an overview of Radformation as a company, what we provide for software solutions, and a little bit of a highlight of the auto contouring software that we have, Auto Contour. So we are in over 2,000 clinics. There are a few countries in APAC that use our software currently. So we are in Malaysia, Hong Kong, South Korea, Australia, New Zealand, and Japan as well. So we do have a few customers in the region, which is great. I've worked in sales in Radong for about 10 years now. And I think one thing that I really like about Radformation is that we were founded by medical physicists. People worked in the clinic. I'm a radiation therapist by trade, so we understand some of the pain points, and I really believe in our products. I think that they do a really great job of improving your workflows. And in the end, what we're all trying to do is improve patient outcomes. So we have invested in the international market. We're an American company, but what sort of sets us apart, I think, from some of our competitors is that we have invested with local representation. So again, you don't need to wait for support to get back online. When America comes online, we have people in the region who are experienced and, who can answer any issues that you may be having. We do have quite a few products. So this is just an overview of all the products, but I'll just do a little bit of a deeper dive into auto contour. So from the start of the treatment, we have auto contour. We have Easy Fluence, which is a really nice automated 3D planning tool, really great for breast patients. You can get a really high quality breast plan out in about 3 minutes. Our checking software, so ClearCheck is an automated plan evaluation software, comes pre-built with every sort of RTOG guideline built in that is all customizable to what your clinic needs. Our secondary MU software, ClearCalc and Rad Monte Carlo, really sort of, this has been one of our most popular products in the region. Chart Check is an on treatment, so making sure that the treatment, as the patients are going through their treatment journey, that everything is looking fine and everyone's okay as that's going on and there's no errors popping up. QuickCode is a billing QA software. It's recently launched in Australia quite successfully, but this will automate any of the billing QA that you're looking for. And then finally, our most popular product in the region has been Rad Machine, which is our vendor neutral automated machine QA software. But I'll just jump into auto contour and just give a few points of what our software does before I hand over to Jeffrey. So we do use, we have over 200 AI structures in auto contour. They are deep learning models that we have. Some really nice efficiency tools that we have built into the software is our automated planning structures that you can generate. So all your PRVs, any overlaps, they can be done at a click of a button. You can have quite a large list. We don't sort of restrict you to how many that you have. Probably, I find the most important part of any sort of AI contouring, it's come a long way in the last few years, but there still needs to be some sort of review that happens. And I think the results that Jeffrey will highlight to you today will sort of show this, that you really still need to not have an over-reliance on AI. It's a tool to help you in your work, not to sort of replace the work that you do. So we have a really nice review process that's automated and goes through there as well. We are one of the most used AI contouring softwares in the world, with over 1,000 clinics using our software worldwide. And yeah, over 1,500 patients get ran through auto contour every single day. We do have quite a few ways that we can deploy our software as well. We try to be as flexible as possible. We have an ACPSEM link, so built into the Eclipse workflow, which is really quite a nice workflow. So no changes to your current sort of work practices. A standard DICOM workflow. So again, just launching it from our auto contour application, and then our zero-click workflow. So detecting that there's a new scan from the CT, and then doing the auto contouring in the background and having those structures ready to be to go into your treatment planning system. As I said, we have over 200 structures. We have quite a few, including MR structures as well. So for the brain and also for the prostate. So you can see that we do have some, you know, if there's structures that we don't have, we do take on customer feedback quite seriously, so we can add additional structures into our software. And again, because we do have those MR structures, you know, we've also included rigid and deformable registration into our software. So again, you know, you can deform and register your CT to CT, CT to MR, MR, PET, etc. Whatever the combination, we can handle those registrations and then add those structures into your planning CT. And then with our ClearCheck software, you can actually do a dose accumulation as well. So seeing what, if a patient had a previous treatment, you can deform that previous treatment and then see what the impact of that previous treatment is on that current treatment that you're trying to prescribe. So that's it from me, just a high-level overview of auto contour. We're very much appreciative of the time that you're giving up for us, but I'll hand back to Professor Cho.
Thank you, Benjamin, for the brief introduction for your company. And just for the audience, for your own information, this webinar has been approved for the PTV points from ACPSEM. So please stay here. Then you'll get email about the CPD point approval within maybe 1 or 2 weeks later. And today, so we will learn about lead formation's deep learning-based auto-controlling system and its clinical impacts. So it is my pleasure to introduce the speaker, Jeffrey Harwood, an ACPSEM certified radiation oncology medical physicist working at R1 Health in Geelong, Victoria, Australia. Jeffrey holds a Master of Science in Medical Physics and a Bachelor of Science majoring in Physics and the History and Philosophy of Science. His professional career spanned clinical roles at Canberra Hospital and involvement in international training initiatives in Vietnam through the ACPSEM Asia Pacific Special Interest Group. Jeffrey's current areas of work include AI controlling, saber implementation, and training the next generation of physicists. He has a diverse background with skills in new technology development, such as EPID dosimetry, field system administration, and maintenance support. So please join me in welcome Jeffrey Harwood. Jeffrey, now it's turn.
Thank you, Professor Cho, for the kind introduction, and thanks, Ben, for the overview of Red Formation's products. I'm just checking people can see my slides.
You can. It's just on the speaker's notes as well. Yep, that's perfect.
Okay,
Jeff.
good. Yeah.
Good. Thank you. Yeah. So thanks for the opportunity to speak. I work as a medical physicist in Australia in Harwood Health, and hopefully I can just share some of our experience with implementing and trialing rad formations auto contour and provide some information that will be useful for you. First, I just want to acknowledge the traditional owners of the land on which I'm presenting, pay respect to their elders past and present, and the Aboriginal elders of any communities who may be here today. So to provide some context of our experience, I'll just provide an outline of the radiotherapy team and the service we deliver at Andrew Love Cancer Centre. The centre has been operating since 1992. We have 3 LINACs, a CT, and a superficial machine. The workforce is made up of 5 radiation oncologists, 24 radiation therapists, 4 ROMs, and 2 dedicated radiation nurses. The Andrew Love Cancer Centre is a pretty comprehensive oncology service with haematology, medical oncology, day ward with 16 chairs, clinical trials, oncology pharmacy, allied health, and a wellness centre to support our patients. Geographically, we occupy an area of approximately 30,000 kilometres square. So the southwest of the state of Victoria. The population of Geelong is about 300k. The population of the region is 450k, but that's a growing region with, expected to be 600k within the next 10 years. We do live near the surf coast, and that's me there. So we'll set some learning objectives for today. So we want to learn how to evaluate an AI-based contouring system, understand the tools and methodologies available for assessing how useful an AI contouring system is within a clinical department, and then also understand the role of risk assessment and quality assurance in the integration of these technologies into clinical practice. We also want to look specifically at the impact of AI contouring on our clinical workflows, so examining the influence of the AI-based contouring tools on the clinical workflows and planning efficiencies. So just a bit of overview about contouring and the importance of it. So radiotherapy planning requires us to precisely delineate structures. We want to identify target volumes to treat and organs at risk to avoid delivering too much dose. So a recent AAPM task group TG275 reported that failures in detecting contour errors in treatment targets and normal structures are the largest and 7th largest risk factors in radiotherapy planning. And so that's probably true irregardless of we're using AI contouring or manual contouring. But it's something we want to look at if we can improve it, the accuracy, and those lines. Manual contouring is also time consuming and prone to variability. So the question is, can automatic contouring improve this process? We can take a look at that throughout this presentation. Just give an overview of the implementation of AI contouring at our department. So in March 2024, we got approval to go ahead with a trial from our new technology and clinical practice committee. Between April and June in 2024, we did a 120-day trial. Through that time, we evaluated 99 clinical cases. In September 2024, we got a full endorsement to go ahead from our new technology and clinical practice. And we're hoping to roll out clinically the end of this year or early next year. So I think the first step in any implementation process is to evaluate what resources are available. So reviewing the literature. And some of this depends on which state you're in, which district, which country, even depends which local hospital. Right? So I thought the key places you can look is first in your local hospital. So we got support from our IT department. We have some committee organizations around the implementation of new technology. We also have committees around ethics and research. So we approached all of these with the information that we were wanting to trial this new software. Beyond that, there's position papers and professional bodies, things like the AAPM, ACPSEM, RANSCA. We also have published literature, scientific papers, and then there's manufacturer documentation as well. So our project has been signed off by the New Technology and Clinical Practice Committee and the Research Development Unit with the full ethics approval and presenting our data. We're going to speak a little bit more on this process later in the presentation. So our RANSCA, our Royal and Australian New Zealand College of Radiologists, have provided some guidelines about the ethical principles for AI in medicine. So they should have 9 key principles that should be adhered to: safety, privacy, minimizing bias, transparency and interpretability, applying human values, decision-making on diagnosis and treatment, teamwork, responsibility for decisions made, and governance are the key principles. We can also look to our local physics group. So we have a working group within the ACPSEM. So the ACPSEM has endorsed the principles I just listed before and does provide guidance for a few other things. Looking on a more international scale, you can see that the AAPM has started to work on this. So there's a task group formed and meeting. This task group doesn't have a position paper released yet. So beyond looking at your local hospital resources and professional bodies, you can look at the literature in general. There's a wealth of literature on AI contouring. I think it's outside the scope of this presentation to do a full literature review. So it's clear from the resources available that there is some guidance in how you would commission an AI contouring system, but it's probably a little bit less defined than something like LINAC QA, where you can provide a protocol recommendation to check your outputs are within 2%. The subtleties of AI contouring are a bit less defined. And it's good to look at the manufacturer recommendations as well. So here's a white paper from Reformation on auto contour. Provides some good information, tells you what kind of deep learning algorithms are being used, discloses where they're getting their data sets from, So it's good to review the manufacturer recommendations as well to understand the AI contouring system you're using. So this is a screenshot of our standard process from going from planning CT through contouring and then planning. So a CT of a patient is taken, then structures are delineated. Typically, our RTs are delineating organs at risk and our ROs are delineating targets. That can change a bit depending on the particular site. Then once the structures are delineated, it's sent to planning to complete the planning and get a suitable dose distribution. So we continue doing that and did a concurrent and assessment of the auto contouring software. So while completing the manual contouring, we got the therapist to send the CT datasets to auto contour, which automatically contoured the structures, and then we could use these datasets for evaluating QA retrospectively. So in this process, we got the therapist to modify any AI generated structures that they viewed needing modification. So we end up with sort of 3 data sets of contours to compare. We have the manual contour, an AI without modification, and an AI with modification. So this is just a bit of how the AI contouring software works, how auto contour works. So CT send is said to auto contour. The cloud generates organ at risk structures. The CT data is anonymized and encrypted before being sent to the cloud. After the contours are exported back to auto contour, the data is immediately deleted from the cloud. And with this, we sort of start getting the first structures ready within about a minute. Once we get the structures back, they're imported into the Eclipse RT planning workstation. So before moving on to how we can evaluate contours and the clinical impact of using an AI contouring system had on our clinic, can consider what can go wrong in the process. But it becomes an interesting question about how you can assess risk. We decided to use our hospital's risk assessment framework. This is a pretty typical framework for assessing risk, where you consider the consequence, the magnitude of the risk, and the likelihood of the identified risk occurring, and you can get a risk class from that. So in doing this, we sort of really identified 2 main risks. First, that auto contour produces a poor quality contour, and then somehow that auto contour corrupts the data. So auto contour could produce a contour that does not represent the patient's anatomy, and that could potentially be used to calculate a treatment delivery. And that treatment delivery might not be optimal, as the delivered dose to the target and organs at risk differs from the planned dose because the contours don't match the actual anatomy. And it's possible, we thought the best way to control this is that all contours will be checked by a clinical staff. And once we put this control in of someone checking the contours, it really reduces the likelihood of this event occurring to rare. The same with auto contouring corrupting the data. I mean, as a new software, we've all seen Terminator, or maybe we haven't, but you know, there's a risk. It's a new kind of software. It's possible that it behaves in an unexpected way. As you know, an example of this could be that it determines the contours and assigns them to the wrong patients. So again, introducing an independent check of the software reduces the likelihood of that contour to rare and really lowers the risk score because of that. So we can move on to comparing contours now. There's a few things to consider when comparing contours, comparing 2 sets of contours. So a biologically perfect ground truth is impossible to produce, as we're defining the contours on a medical image, and these have contrast and resolution limitations. So manually delineate contours produced by professionals, RTs or Os. They get labeled as clinically acceptable, but clinically acceptable is a bit of a vague and poorly defined term. It's difficult to quantify what degree of variation is acceptable in a contour. Manual delineation is subject to observer variability. This includes manual steadiness, attentiveness, expertise, and the subjective interpretation of the observer. And comparisons of auto-contoured and manual contours can be complicated by the fact that the original contouring may consider things other than just the primary images. So this could be PET images, MRI images, physical exam, endoscopic examination. So there might be extra information used to create the contours that isn't available to the AI contouring system. So we can look at quantitative tools to compare contours. The quantitative evaluation methods are objective and deterministic, which is probably appealing to physicists. All physicists, most physicists, I'm not sure. We certainly do like to crunch numbers. I think we all realize as working in the field of medicine, things are not always fit into a simple equation. So this is a summary of the tools available from McKay et al. So in terms of geometric metrics to compare an auto contour to a ground truth contour, we can use classification accuracy. So this is assessing if voxels within and outside an auto contour have been correctly labeled. We can use overlap-based ones, so this is probably the most commonly used. This is something like DICE, so assessing how well the two contours overlap. Can use volume-based, so comparing the volume of an auto contour with the volume of a manual structure. There's surface-based, so this is things like Hausdorff distance, which is also commonly used in literature. Compare the distance between the surface of the structures. This can be maximum distance, average distance. There's moment-based, so comparing the center of the reference structure, center of mass. So beyond geometric metrics, we can also look at dosimetric metrics. So you can calculate plans with different contours and see the effect on DVHs and Dmax for different organs. Can do time-saving metrics, so comparing how long it takes to contour structures manually and how long it takes to contour with auto-contouring. And there's qualitative metrics as well. How good is an individual contour, either AI or manual contour, or just rating the contour without knowing if it's AI or not. Not knowing makes that a blinded test, or what they refer to as a Turing test. So there are a few tools available. Use 3D Slicer with the RT extension. That's a Python-based open source software. You can do Hausdorff distance, you can do DICE here. And then also within Eclipse itself, you can get some of these metrics. So DICE, center of mass, shift, and volume change. So I'll talk a bit about our experience with quantitative evaluation. So before undertaking the comparisons, we noticed there was a building body of literature that demonstrated that quantitative metrics are poorly correlated with arguably more important factors, such as physician review or impact of differences on the patient. But we still thought it was worthwhile to investigate quantitative metrics, one, to test for this poor correlation, and also to gain some local experience and potential understanding in the use of Radformation's autocontour and the available metrics. So we reviewed the results of the first 10 initial cases. We then made a decision to cease the quantitative analysis. We saw this poor correlation mentioned in the literature, and the additional numerical data was not a useful tool for evaluating the suitability of autocontour for ongoing clinical use. I'm going to provide some examples in the next slides about that illustrate this decision. So here is a screenshot of an ear. The contour is the inner ear. The manual contour is more generous than auto contour. You get quite a poor DICE, 0.48, where a DICE of 1 would be perfect agreement. But both these contours were deemed as clinically acceptable. I think even if the manual contour is a bit more generous about organ at risk, it's only become an issue if it was compromising the dose, and it's a very small structure, typically not near the field. treatment. So here is an example of an esophagus. So the esophagus close to the region of treatment agrees quite well. So if you did a dice of just this region here, you would get a pretty good dice score, but the AI contouring has extended beyond our manual contouring. And this leads to a poor dice. So the auto contour and the manual contour are doing a very similar job, but you get a low dice score because of just the extent of the contour. And here's a case of a humeral head where the AI has done a pretty poor job. And this could be that it's not a fair use case for the AI because the CT set is truncated, but we can see that the humeral head is wrong, and a good example of why you would want to check. So we also did time studies. So here's a picture of the form we used for this. So we got RTs to just use a stopwatch, do the manual contouring, reset the stopwatch, send the CT dataset to auto contour, make any edits they required, and record the finishing time of each. So on average, we saw that just using this auto contour to get the first stage of the contouring, making edits, we still were saving 50% of the time. So here in this graph, if it was at 100%, it would be the same time, and the lower it gets, more time savings. We also looked at individual sites. You can see that the amount of time saving does vary from site to site. And it's also worth noting the time saving in percentage doesn't always map to the time saved in minutes. So you can see we get some pretty big absolute time savings for head and neck cases, and some really, look at the max and min, there's quite a few. So this is the time taken for each. Just zoom in a bit like graph so people can see. So auto contour with edits is the purple, and the green is manual. So you can see nearly all the time we're saving a time by using the AI contouring. I'm just providing a few of the comments that were listed from the users during the trial. So some good positive feedback, and then sometimes it was not doing as good a job as we would like, especially in some unusual anatomy and the humeral head case, which I discussed before. So just go back to the NTCP and the requirements they had. Your organization might have something like this. If they don't, this could be things you want to consider. So the NTCP committee is chaired by the Director of Medical Services and includes medical members of all heads of units, medical, nursing, children's services, research, finance, pharmacy, patient safety, and IT. Every project that we want to go ahead is examined by them, and here's the criteria they look at. So whether it's safe, efficient, and effective, comparing it with other major services delivered, the capacity for our organization to implement that, financial and staffing, other resources, the ability to credential and the scope of the practice and training needed to do that. So our time saving studies suggest that it's efficient, that most contours have a good geometric agreement, confirms the accuracy. This is also furthered by the fact that the product is TGA approved. And for our trial, it was a retrospective evaluation. We used separate data sets, and we had good routine QA processes in place for contouring already, following national clinical protocols, and we're regularly audited through the radiation oncology practice standards. I think it's good to consider quality management in these cases as well. So quality management is essential in radiotherapy to ensure patients get effective treatments. We should have consistent monitoring and evaluation and improvements to all aspects of the treatment chain. It would apply to auto contouring. I think it also, good quality management systems, foster continuous professional development, make sure we adhere to clinical guidelines and ensure that we're compliant with regulatory standards. So this is the basic quality management checks we came up with for implementing AI contouring. So recontouring a typical reference data set, checking the software is up to date, reviewing any safety recalls, advisories and TGA notifications, and doing an independent review of the implementation and analysis of any quality control results. So in summary, we've reviewed the resources available to assess auto contouring software in a RT department. The main takeaway message for us going ahead with the clinical implementation is that the auto contouring saves time. It's also important to note that auto contour still requires a review of the contours. It gets it wrong sometimes. Just want to do a few acknowledgements. The project team, so RTs Ken and Philip. Ken in particular, I've used some of his slides today. The physics team, Flavio and Chu. Our radiation oncology team and ALC Cancer Services executives, and the new technology and clinical practice committee and the research development unit. And here are a few references I've used throughout the presentation. Thank you.
Thank you, Jeffrey, for sharing your experience about the red formation AI contouring software and how to implement that based on the new technology clinical practice committee formation. I have several questions from our audience. Let me check it first. So one question is that as each similarity metric perform differently for different OARs, how would you evaluate the overall accuracy of the tested auto-segmentation model?
Yeah, that's a good question. And it's definitely true that you apply different metrics. So if you use DICE or volume-based or Haskell distance to compare an auto contour with a manual contour, you can get different results. And you also see that those results can differ to what you would define as clinically acceptable. So I think those examples I showed with the inner ear, the esophagus, and the humeral head showed that, these quantitative metrics are not quite mapping to what we would call as clinically useful. So we just have to accept that and look at, I think, the time-saving methods, time-saving metrics show a better outline of what we can do as a clinically useful way to assess auto contour.
And I think also you showed the difference from DICE coefficient difference for the esophagus, but actually it's the difference came from the kind of the definition of anatomy. So I guess you're only for the treatment, radiation therapy treatment planning purpose, we only need to draw the esophagus within maybe treatment field, around the treatment field. But actually the anatomy itself is expand more than that. So that might be explain the difference. So just the value itself doesn't mean in this case, right?
Yeah.
Do you agree? Yeah. And also if the organ is not scanned fully, the organ cannot cover the fully scanned, then definitely there should be some kind of error. We can imagine that kind of error, right? And then the next question is that do you have an evaluation matrix threshold window value to judge the accuracy of auto segmentation algorithm?
Yeah, I think this is a related question, and so no, we didn't come up with one, and it didn't seem possible to do that because of how dice could be so different for two structures that were basically the same, outlined the same. So auto contour and manual contour were both clinically acceptable structures, but dice was very different, volume change was different. So it's very difficult to, get a threshold where you have a contour, a dice score of 0.94 means that structure is clinically acceptable, because it goes both ways. You can get a poor dice score and the contours, an auto contoured and a manual contour are good. They're both okay. And the same, it goes the other way, where you have a high dice agreement, but the contours are, one contour is viewed as clinically acceptable and another is not. So just these metrics they're poorly correlated with clinically acceptable. That's well documented in the literature, and we found that through our local investigations as well.
Okay, thank you. And another question from Muhammad Ikmal is quite sounds like challenging. In scenarios involving adaptive radiotherapy, where patient anatomy changes over time, could RLNs play a role in predicting contour evolutions? And how do you see this impacting future AI-driven radiotherapy practice?
Yeah, so I think auto-generated contours are going to become a big part of the future of radiotherapy, particularly in adaptive radiotherapy. It's quite simple to think about how this would happen. You can get something like a CBCT on the day. As that's happening, the contours are produced in no time at all, and you can compare these contours on the fly to flag changes in anatomy that might be clinically significant. Tumor shrinking, or there's some weight loss and the anatomy has shifted around. So it's an exciting space to look forward to. That really was outside of scope of what we looked at with our implementation here. We're doing that first step where we're using this tool mostly because it saves us time and work. But it is exciting, and hopefully that as these tools become more established in our practice, we can see them changing how we treat to give higher quality treatments to patients.
Okay, and another question is that from Gaganpreet Singh, he's asking, is it possible to say AI contouring is a universal solution? Quote, one size shoe can fit all? Or is this customized solution for the clinics?
Yeah, so the deep learning models are trained off a limited set of contours. I think all approaches in radiotherapy, our treatment prescriptions, our fractionations, they rely on an assumption that what has worked for a patient previously will work for a patient in the future. If we didn't have that, we couldn't, deliver 40 gray to this kind of treatment type and get a positive outcome. But we have to be cautious of that, and I think particularly, knowing what the data set is that's trained on is a key consideration, and it might be biased, so that needs to be looked at. And whether it's customizable solution for the clinics, I think that the models aren't customizable, but the software itself is customizable. So, you know, things like different PTV margins, expanding this is customizable, so it can fit different parts of the clinic, but not all.
So I have the similar question. The Astro and Istro, they provide the guidelines for how to control the normal organs and also the target volume. But in some hospitals specifically, we use like the bladder filling or bladder voiding treatment, or some hospital can put some low density contrast to draw bladder more easily inside the bladder. That kind, or actually in our hospital for the breast cancer patients, we only arm up in the ipsilateral breast, not the contralateral breast arm up. So this kind of position difference maybe affect the quality of auto controlling if the data itself is not trained in that situation. So that kind of all thing can be further fine-tuned for specific to the hospitals. Do you agree?
Yeah, it could. I agree that if there's some kind of local protocol that makes the anatomy of a patient different to what an AI model was trained on, then that could potentially cause some problems with the auto contours that software produces.
So I am wondering,
commercial softwares aren't letting us train the models, so I think
I'm wondering, lead formation also support that kind of the hospital specific fine-tune somehow solution.
So it's not. I don't think it's fine-tuned on a per clinic basis. Ben might be able.
Yeah, sorry, I can jump in here. We don't fine-tune the models on a site-specific level. This just sort of causes a lot of issues in regards to regulatory challenges. We have to submit how we train our models, etc. For regulation purposes. But we do have quite a significant data set. There's arms up, arms down, those sort of things don't really impact it. What we do see, what impacts, the AI models are the things like prosthetic hips. If there's bilateral hips or something like that, we can usually handle contrast and things along those lines as well quite well. I saw that there was a question about if the modified contours, are incorporated into the training, though they are not. And that's mainly because of that sort of regulatory issues that we can face in regards to that. But if we do have a nice built-in tool. If there's something that fails or there's a problem, you can send anonymized patient data directly to Radformation, which we can then build that patient into our training data set for further training of the model. So yeah, there is the ability for hospitals to provide scans into our training sets with that. But yeah, we don't do site specific models just because it would sort of get a little bit challenging for us on a few levels.
And there is also the similar question from Narmada. She asked, does the modified contours after AI contouring reincorporated for training, like a cycle process to improve the contours?
Yeah, no, they don't, but we do keep track of, so we can keep track of what contours are modified, but we don't use any of the clinic's data to train the model. So it's we would just take that feedback from the uploading of the anonymized scans. And yeah, as I said, we do sort of very much appreciate if there's feedback from sites that a certain model's not performing well. But mostly the models, and the training sets that we have sort of produce, quite high levels of contours.
Okay, thank you. And there is also another just comment from Sanguti. His opinion is that the clinical validation process requires radiation oncologist to determine whether an edit is minor, unnecessary, or major. That could be a metric, right? Important metric, yeah.
We did look at this for a few cases, and it is interesting, and it would give you some confidence that if all changes are minor, and this was our experience with auto contour. I don't have analysis of that because we're doing that with comments within the structure set, so it's a bit difficult to get for all 100. But yeah, it is useful information, but even if all edits were major and you were still getting time saving from the auto contour, then it still might be a clinically useful tool. So
okay, I think it's there are some more questions, but I think it's because we already spent almost 1 hour, so it's time to close this webinar. Thank you, speaker and Benjamin from the Red Formation and all the audience and very exciting questions and comments. Thank you, everybody.
thank you, Professor Cho.
Thank you. Thank you. Thank you.
Yes,
Thank you.
from AFOMP, I would like to introduce
Mary, your connection is, yeah.
thank the speaker. I would like to thank the speaker of today, Jeff, for the very interesting talk, very informative and useful for all the participants and all the members of formation, and Benjamin especially for joining in clarifying the doubts as well as presenting the introduction, and members who have joined us today from the right formation. Thank you very much for this collaboration. Looking forward to many more. And thank you, speaker. Thank you, moderator, and all the participants who have actively joined today and enthusiastically asked questions. And we meet for the next webinar. Bye to everyone. Thank you.
Thank you, Mary. Thank you, everybody.